What's going on, guys? My name is Ahmed, and today I'm going to be going over the cardio and endocrine pharmacology. So without further ado, let's get started. So first thing we're going to cover is angina. So let's just review real quick before we dive into angina about oxygen demand and what it's determined by. So there are four things that do determine this, which are heart rate, contractility, preload, and afterload. So on the other hand, oxygen supply is determined by myocardial, or the heart, blood flow. Okay, so let's just keep that in mind. The four things that need to be taken into consideration for oxygen demand are heart rate, contractility, preload, and afterload. So what is angina? Why do we care about this whole oxygen supply and demand thing? Well, we want to know about angina, and that's what this lesson's about, correct? Well, angina is actually precipitated when oxygen supply to the heart is not enough to meet oxygen demand. So there's like an imbalance in the system. So we can look at it in the schematic here. Oxygen supply and demand. For a healthy heart or normal people, oxygen supply and demand are equal. There's enough oxygen to meet the heart's demand, and that's due to the having sufficient supply. Now, if we have a diseased heart or a heart with any type of underlying disease like cardio or atherosclerosis or whatever it might be, there becomes this imbalance in the system, as you can see on the right hand side. So the oxygen supply is not enough to meet the demand, and therefore things can precipitate. That's what we talk about angina. So angina is actually defined as pain beneath the sternum and often radiates to the left shoulder, left arm, and the jaw. So similar to what we would think of when we talk about heart attacks. So this is precipitated when, again, there's that imbalance in oxygen demand and supply. Not enough supply to meet the demand. Now, we now understand and know what angina is, but there are three different forms of angina, just to make it a little more complicated for you all. So we can start with chronic stable angina, which is also known as exertional angina. There's variant angina, or Prinzmetal's or vasospastic angina. And lastly, there's unstable angina. Now, specifically for this class, all you need to know is chronic stable and variant angina and the difference between the two. So, chronic stable angina or exertional angina usually is caused by coronary artery disease and plaque buildup. And this is triggered most often by an increase in physical activity. So again, it's that exertion. Also, emotional excitement, large meals, and even cold temperatures can cause an attack or cause you to get precipitate a chronic stable angina type symptom or type event. So a way to remember chronic stable angina, again, it's exertion, so also known as angina of effort. We can think about relationships. So to keep a relationship stable, one needs to put in effort. So a way to think about it, chronic stable angina, stable relationships, put in effort. So that's a way you can maybe think about it. Variant angina or Prinzmetal's, and the reason it's called Prinzmetal's is a person named Prinzmetal, of course, coined the term way back when he found or put a name to it. So that's why it's also known as Prinzmetal angina. And there's vasospastic is another name for it. So the underlying cause for this is a coronary artery spasm, which restricts the blood flow to the heart and could be triggered at any time, even during rest and sleep. So if you think about it, if this can be triggered in your rest or sleep, that can be pretty dangerous, and therefore variant angina can kind of be considered a little more dangerous than stable angina. Now, the goals of treatment. So the goal is to reduce the frequency and intensity of these attacks. And of course, with the goals of treatment, we can talk about the different medications and their mechanisms that are used to treat angina. So I know this slide is a little busy, but we can think about the nitrates or nitroglycerin. So in stable angina, the mechanism by which these nitrates work, and again, nitrates are venodilators. So it decreases the oxygen demand by dilating the veins, which decreases preload, Again, going back to the four fundamental things that we talked about in terms of oxygen demand at the beginning were contractility, heart rate, preload, and afterload, correct? Those are the determinants. And here we can see that we decrease oxygen demand by dilating the veins and then therefore decreasing preload. Now, nitrates in variant angina decrease oxygen supply by relaxing the coronary vasospasm. So although it's the same drug, if you have, depending on the type of angina you have, there's different mechanisms by which these work. Now I'll move on to beta blockers and where they're used in angina. So beta blockers are, and we use propranolol and metoprolol, and that's just using following guidelines, even though one is beta selective and the other. So propranolol is not beta selective, metoprolol is, but they're the ones that are used in current practice. Now in stable angina, we use beta blockers because they decrease oxygen demand by decreasing heart rate and contractility. But in variant angina, beta blockers are not used. And make sure you keep that in mind, because you never want to give a beta blocker to someone with variant angina. But in stable angina, it is an option for treatment. Now I'll move on to the calcium channel blockers. So, and these are, again, medications that you should have some exposure to from the previous chapters. But we have verapamil and nifedipine that are used. And both are used kind of just it's dependent usually on the patient, but patient characteristics. But here we're just going to talk about it kind of broadly. And so verapamil and nifedipine, you can just think about them as the calcium channel blockers used in both stable and variant angina. Now, calcium channel blockers are used to decrease the oxygen demand by dilating the arterioles and thus decreasing heart rate and contractility. Again, the four things that have to do with oxygen demand: contractility, heart rate, preload, and afterload. So therefore, it does make sense by the mechanism which these calcium channel blockers work. In variant angina, on the other side, they increase oxygen supply by relaxing the coronary vasospasm. Because again, variant angina is also known as vasospastic. So that's another way you can kind of keep it in your mind. And lastly, let's see here. Ranelzine appears to decrease oxygen demand in stable angina, possibly by helping the heart generate more energy more efficiently. So that's just, it's in theory, the mechanism by which it works. In variant angina, ranelzine is not used. So remember, beta blockers and ranelzine are both not used in variant angina, while the other medications, the nitrates, beta blockers, and calcium channel blockers, are used in both stable and variant angina. Whew, okay, that was a mouthful. So we're going to talk about each medication in terms of like little specific tidbits that you should know for each of them. So the nitroglycerin, again, the vasodilators, and I guess I kind of have it written out there, but nitroglycerin acts on muscles as a vasodilator, and that's first and foremost what we should know about it, its main mechanism. And generally, nitroglycerin is well tolerated, but there are some side effects that can precipitate, including headache, orthostatic hypotension, and reflex tachycardia. And we talked about these things in previous chapters. Now, big safety alert. Notice all the bold, all the caps. Concurrent use of PDE5 inhibitors. So remember, the phosphodiesterase type 5 inhibitors with nitroglycerin is an absolute contraindication. We will never use those two. So patients that are on PDE5 inhibitors will not be using nitroglycerin. Absolute contraindication. Nitrates can increase cGMP formation, and PDE5 inhibitors decrease cGMP breakdown. So if used together, the cGMP imbalance can rise, which it can rise and become dangerously high because they have basically opposite mechanisms, causing excessive vasodilation and a huge drop in blood pressure, which can be extremely dangerous because we talked about hypotension as well, and the possible issues that can arise with that. So remember, PDE5s and nitrates, or nitroglycerin, no-go. And of note, sublingual nitroglycerin works very quickly. It's in about 1 to 3 minutes, and this is something that's conventionally used. But if symptoms don't go away after 5 minutes after giving someone sublingual nitroglycerin, the patient should call 911 or report to an ER immediately. And why is that? Because, again, anginal pain that we described, that pain in the left side, left shoulder, left jaw, left area of the jaw, if it does not respond to nitroglycerin, may indicate an MI, or a myocardial infarction, a heart attack. And that's the only way to kind of differentiate that is what happens after you administer nitroglycerin. Does the pain go away or not? If it doesn't, potentially it could be a heart attack, so call an emergency response or just dial 911 as soon as you can. Now, while waiting for emergency care, the patient can take an additional sublingual nitroglycerin and then a third one even 5 minutes after. So in 5-minute intervals, you can take extra doses until the ER or the emergency room or the emergency response team arrives to your location. So I have some case studies here, and we can just go over them together. So let's take an example case. A 42-year-old man was walking his dog on a beautiful Sunday morning when all of a sudden, he started feeling some severe chest pain that radiated to his left arm. Fortunately, he was conveniently only a few steps from his home, so he rushed to his bathroom quickly and reached for a bottle of blank to treat his chest pain. Of note, he does have a history of coronary artery disease. So, which medication do you think he reached for? A. Propranolol, B. Verapamil, C. Nitroglycerin, or D. Rinalzine. We'll give you guys a few seconds to think about it. Dun, dun, dun. Alright, and if you guessed he reached for his nitroglycerin bottle, you are correct. So again, it precipitated some pain, and the first thing that you want to use for anginal pain or an anginal attack is nitroglycerin. The others are more long-term use or prophylactic measures, but if you're having an attack, that nitroglycerin is what you're going to be wanting to use. Now, another case study. After the patient took his medication, he noticed that the symptoms did not go away. So what should his next step be? Should he take another dose of the nitroglycerin, call 911, both A and B, or none of the above? Give you a few seconds to answer. Alright, if you chose A and B, so answer C, you are correct. He should definitely take another dose while awaiting the response team, because that's what we said patients have to do. And of course, also call 911 immediately. Alright, and yet another example. I like examples, as you guys can see. So which of the following is not true with regards to the difference between stable and variant angina? So, beta blockers are effective in both types of angina. In both types of angina, prophylactic treatment is possible. Nitroglycerin should never be used with PDE5 inhibitors. Or D, calcium channel blockers are effective in both types of angina. So which of the following is not true? A, B, C, or D? Give you a few seconds here. If you chose A, you are correct. So beta blockers are effective, or the answer says beta blockers are effective in both types of angina, which is not true. Beta blockers are only used in stable angina and not variant. Okie dokie. Well, that's all we need to know about angina. So, next up, why don't we talk about the anticoagulants? Alright, if you're looking at this and not just listening, you can see this crazy schematic of something we call the coagulation cascade. And it's pretty busy to look at. And thankfully we don't have to know every little tidbit and every piece of it, but rather just a few things in terms of just understanding kind of where these anticoagulants act and why we even refer back to this coagulation cascade. So as you can see, different medications act at different spots in this coagulation cascade. As you can see, vitamin K antagonists like Warfarin, which most of you are probably aware of, acts at different areas of this cascade. So factor 10A, as you can see, thrombin, it has all these different places that it acts. So depending on which medication we're talking about, if you want to ever look back at the schematic, it can show you exactly where the drugs act in this cascade. Alright, so we'll move on to the prototype drugs. So anticoagulants. So there's the drugs that activate antithrombin, which are heparin, unfractionated, or enoxaparin, the low molecular weight heparins. Also, the vitamin K antagonist, which we'll know as Warfarin, direct thrombin inhibitors, or dabigatran, the direct factor 10A inhibitors, rivaroxaban and apixaban. And now there's also some antiplatelet and thrombolytic drugs. Again, thrombus, so a clot, and then lytic, lysis, breaks down, if you want to break down the word there. And antiplatelet drugs that we will talk about are aspirin, which is a COX inhibitor, which you should all be familiar with from previous chapters. Clopidogrel, which is a P2Y12, specifically ADP receptor antagonist. abciximab, and that's a glycoprotein 2B3A receptor antagonist. And lastly, the thrombolytic drugs, which are streptokinase and alteplase. So alteplase and streptokinase, they're the tissue type plasminogen activators. All right. So in terms of general anticoagulants, when we think about them, there's some side effects that we should all be aware of. And when we use anticoagulants, we need to make sure that patients do not form clots, right? So embolisms, DVTs, etc. Now, what do you think would happen systemically when we think about disrupting the natural clotting cascade? So the coagulation cascade that occurs naturally, we're disrupting this, right? So if we're disrupting it, what are some big side effects that we think of? Bleeding. Yes, if you guessed bleeding, you are absolutely correct. So the natural response to in the body is to create, it should have like the perfect mechanism to clot the blood. But again, since we're using anticoagulants, which can cause therefore the blood to be more, I don't know, fluid, if you will. Probably not the right term to use, but just, again, the blood flow and blood will just be so much less clotted. Therefore, if you have a cut or anything disrupted in the body, it can cause you to bleed. So what do we need to think of in terms of bleeding? So too much anticoagulation. Patients should be monitored closely for signs of blood loss. That's first and foremost. And these can include reduced blood pressure, increased heart rate, bruises or hematomas, red or black stools, and discolored urine or hematuria. And things to really look out for are, make sure to let patients know that, hey, if you're, don't just think about bleeding in terms of cuts and things like that, but also like the discoloration of stools, so red or black stools and discolored urine. These aren't things that most people think about in terms of bleeding, but these are most common. Those are the signs that really will tell you, okay, there's a bleed going on, potentially a dangerous bleed. And bruises, don't think about bruises in terms of just random, or not bruises from falls or specific areas where you would typically find bruises, but rather in areas like the trunk of the body and things like that, where you wouldn't expect bruises. So if those start to appear, that could be a sign of maybe they're overly anticoagulated. All right, so there's a difference between two of the antithrombin medications I talked about, which are low molecular weight heparins, enoxaparin, and heparin unfractionated. Low molecular weight heparins, or LMWH, is what you'll probably see in practice or in textbooks, are simply just heparin preparations that are shorter molecularly. That's the only difference, really. Low molecular weight heparins are just as effective as unfractionated and are easier to use because they can be given at fixed doses and require no APTT. APTT is just the activated partial thromboplastin time, and it's just a way for monitoring, which is the clotting time monitoring. Okay, so APTT is just used to basically assess or monitor patients that are on heparin. Low molecular weight heparins are advantageous because they can be taken at home and does not require coagulation monitoring like heparin does, as mentioned in the above. Low molecular weight heparin is more expensive than heparin, so that's also something that we should take into account. So it's more effective, sure, not more effective, excuse me. It's as effective and more convenient, but with convenience comes expense. And lastly, low molecular weight heparins are more bioavailable than heparin is. Now, warfarin. This is the one that most of you probably have heard of in the past. And warfarin is just a vitamin K antagonist and is the oldest oral anticoagulant in the book. Similar to heparin, warfarin is used to prevent thrombosis or clotting and clots. However, warfarin has a delayed onset, which makes it inappropriate for emergencies. Again, warfarin should not be used in emergencies. It is an oral agent, making it great for long-term prophylaxis, and patients love oral medications and despise injections. So, as you can see, a lot of people will probably elect to take warfarin over injectables or whatever it might be. Now, additional information about warfarin is that the anticoagulant effects of warfarin are evaluated by monitoring prothrombin time, the PT time, which is a coagulation test especially sensitive to alterations in vitamin K dependent factors. The average pre-treatment value for prothrombin time, or PT, is 12 seconds. Okay? And treatment with warfarin prolongs PT. So when you give a patient warfarin, their PT time should be longer than that 12 seconds. And PT test results have always been reported as a PT ratio, which is simply the ratio of the patient's PT to a control. That's something you can get in a lab. And the problem with PT ratio is there is variability from lab to lab, because again, you take a patient's PT and a control. That control changes from depending on what lab you're going to, and because the variability in the thromboplastin that's used. So to ensure results are comparable from lab to lab, results are now reported in INR, or the International Normalized Ratio. So this is something that you should be familiar with. Again, it's the INR, the International Normalized Ratio. Now, what is INR specifically? For the most part, INR, this is in terms of just the numerical value. For the most part, recommended INR targets for most patients are 2 to 3. And these are patients who are anticoagulants. If the INR is below 2 to 3, warfarin dosage should be increased. If the INR is above 2 to 3, warfarin dosage should be decreased. So you have to remember, it's kind of like the opposite. So low INR, dosage increase, higher dose. And then high INR over 3, warfarin dosage should be decreased. And unfortunately, because warfarin has that delayed onset and prolonged duration, the INR cannot be altered immediately or very quickly. So it can take a week or more to see changes in the INR value. So how do we monitor this INR thing anyway? Well, INR must be determined frequently during warfarin therapy. So first, patient should be measured or monitored daily during the first 5 days of treatment. And then next on, for basically the second part of after initiating treatment, twice a week for the next 1 to 2 weeks, and then once a week for the next 1 to 2 months, and thereafter every 2 to 4 weeks. Okay? So I'm telling you guys that a patient has to come to the clinic that often? No, thankfully not anymore, because INR can now be monitored at home. So there's things like the CoaguCheck, the ProTime, microcoagulation system, and etc. There's all these different monitors that now can be monitored at home, and again, it's just a lot more convenient for the patient. Now, some general considerations with warfarin is just think interactions. Probably the drug with the most interactions in the market. Warfarin can cross the placenta, so of course it's contraindicated with pregnancy and lactation. And as you can see, there's a long list of all these different medications that interacts with and effect of warfarin in terms of what happens when you take these medications and what it can cause to INR. So it can cause an increase, decrease, etc. So what I would like all of you to do is make sure you learn these meds, learn the effect on the INR and the proposed mechanism, please. That'd be fantastic. And that should be on at least a few questions on your exam. Alrighty, so many interactions, and by the way, I'm just kidding. Do not memorize these, okay? You can just look them up when needed. But although there are many interactions, there's one important one to keep in mind, and that is gemfibrozol. And warfarin, when taken together, gemfibrozol causes an increase in the anticoagulant effect of warfarin. So again, gemfibrozol causes an increase. Notice the bold, all caps there. Yeah, probably important to know. Now, what is the proposed mechanism? Cytochrome P450 enzyme inhibition, changes in coagulation factor synthesis, displacement from protein binding sites. So no one's 100% certain, but regardless, we should monitor INR closely if a patient is on these concomitantly, and any of the aforementioned, or the ones before mentioned, I should say. Now, as you guys know, I like these patient cases. So let's just say a patient is being discharged from the MICU who is admitted due to being diagnosed with a deep vein thrombosis, or a DVT. You look and notice that she's receiving heparin to treat her DVT. Her discharge medications include enoxaparin, a low molecular weight heparin, as mentioned before. So which of the following do you think is false? Enoxaparin is only given as an injection, never IM or sub-Q. Never IM, only sub-Q. Enoxaparin is given at a fixed dose. Enoxaparin is cheaper than heparin. Or D, enoxaparin can be taken at home without coagulation monitoring. So I'll give you a few seconds to think about that one. Now, if you chose C, enoxaparin is cheaper than heparin, to be a false statement, you are correct. So enoxaparin is more expensive because we said, although it is more convenient than using just a regular unfractionated heparin, it is more expensive because that's usually what happens. If something's more convenient, it might be more expensive. So yeah, C is the correct answer. Now, which of the following is the recommended therapeutic range for INR? The therapeutic range for INR is at 1 to 2, 2 to 3, 4 to 5, or 6 to 7. Give you a couple seconds because most of you should probably already know this. And if you guessed B, 2 to 3, you are correct. All right. Now, I know we're jumping kind of fast through these different chapters, but now we're just going to talk about STEMI, or ST elevated myocardial infarction, or ST elevation, excuse me. So as you can see, I have two images here. And if you look at the difference, so the top one would be a normal ST segment in an EKG reading. If you look at the bottom, there's an elevation there between the S and the T segment. As you can see, it goes up there. So this here is what we call a STEMI. The elevation in the ST wave is what we call a STEMI, or a ST elevation myocardial infarction. Okay? Now, how a patient can present that comes to the hospital. So again, that chest pain, so that maybe angina type symptoms, severe chest pain, pain radiating to the left arm, the jaw, and of course the EKG changes or ECG changes are an obvious indicator as well. So acute STEMI produces changes in EKG because conduction of electrical impulses through the heart become altered at the site of injury. So there's an infarct basically that's occurring in the heart's myocardium. And elevation of ST segment occurs immediately in response to acute ischemia. So when you see that ST elevation, it's due to there's an inadequate blood supply to a specific area of the heart. So that's a way we can also think about how a patient can present. Now lastly, there's biochemical markers that we can look at, and when the heart muscle dies, there's these release of intracellular proteins, which are cardiac troponins and creatinine kinase. So these are two probably you're familiar with from maybe a biochemistry class, or I'm not sure where else you might have seen them, but again, yeah, these are the two that we look at. But in today's day and age, and at many hospitals, the cardiac troponin 1 and cardiac troponin T are the best serum markers for STEMI. So these are the two that we look at. All right, so now, how can a patient present? That's what I told you guys I would let you know. So patient John Doe, for example, arrives in the ER complaining of severe chest pain that has lasted longer than an hour and is unrelieved by nitroglycerin. So going back to angina that we talked about, he did what he had to do. He got to an ER because nitroglycerin did not help his anginal pain. ST elevation is seen on his EKG. Initial cardiac troponin levels are not elevated. Okay, so this is common, by the way. If you don't see an initial cardiac troponin level, an elevation in those, that is quite common. All right. And in terms of treatment, so if a patient does present this way, you think Mona. This is how I learned it in school, and it's a pretty simple way to think about it. So think Mona Lisa, Mona. So morphine, oxygen, nitroglycerin, and aspirin. Those are the four medications that we think of when treating a STEMI. Now, beta blockers are also used, atenolol, metoprolol, to reduce cardiac pain, infarct size, and short-term mortality. And it's something that just through research and over time has been applied to the guidelines. So morphine, oxygen, nitroglycerin, and aspirin, Mona, is a way to kind of commit it to memory. In practice, though, we don't follow Mona's order, M-O-N-A, but rather we follow this order here on the slide. So first, we will give a patient oxygen to potentially reduce the infarct size by nasal cannula. So we wouldn't give, I don't know, oral oxygen. It'd definitely be through a nasal cannula. Next, we will administer chewable aspirin, and no other NSAIDs should be used. Only aspirin because it suppresses platelet aggregation, producing antithrombic effects, which is needed. Then we will administer IV morphine because it is the treatment of choice for STEMI-associated pain. And then lastly, beta blockers and nitroglycerin will be administered to reduce cardiac pain, reduce preload and afterload. Oxygen demand and supply. You guys can see why it was so important to mention at the beginning. And at the same time, increase blood flow in the ischemic areas. Nitroglycerin, again, is a vasodilator, and therefore that's what would cause the increased blood flow into the ischemic area. So what are we doing, or what are we going to administer first for John Doe? A, oxygen. B, chewable aspirin. C, morphine. D, nitroglycerin. E, atenolol. Or F, ibuprofen. Give you a few seconds here. 4, 3, 2, 1. All right, if you guessed oxygen, you are correct. So oxygen will be always administered first for patients that are presenting with a STEMI. Hooray! John Doe is now stable. Whew. So that was actually quite a bit of cardio. Now, how about we move to some endo or endocrinology to change pace a little bit. So I'll catch you guys on the next video to talk about endocrine diseases like diabetes and thyroid disorders.